So this should be a relatively short presentation focused on the importance of health data systems for cancer control. But it is, I think, important to remember the issue because it often involves ministries beyond ministries of health to make good progress. So the key themes here are the importance of integrating cancer data systems with general health data systems, as well as with national identification systems. And if we're able to do that, we can then work to establish baseline cancer data, and we certainly have seen a lot of that yesterday and today. We can evaluate progress in cancer control, and we can also follow individual patients through the health system or health systems. And we've certainly seen data in terms of the delays between symptoms and diagnosis, between diagnosis and treatment, but having good data systems in place will enable us to do those studies much faster. We know we need to link data from primary care sites, from the district hospitals, the regional hospitals, as well as national hospitals or referral cancer centers. And in a number of countries, healthcare is delivered in public sector, in the private sector, as well as in faith-based medical systems. And ideally, we would be able to link data across those three different systems. So I'll start with vital registration, which concerns itself with births and deaths. And again, often this is not part of the, necessarily part of the Ministry of Health. It may be in a separate ministry. But it is important that we think about how people receive a national identification number. Often this is assigned at birth, as well as the other phrase that one sees is a unique personal identifier, or UPIN. And I think that one of the best examples we've seen is in India, where they have established what they call their Aadhaar system. It's a secure digital identity system, which includes both the UPIN as well as biometrics using fingerprints and an iris scan. And they've rolled that out for 87% of the Indian population. They use it for government programs, for cash transfers, as well as beginning to integrate it in the health system. So I think that's it's a good model that we may be able to get some technical support from the government of India. And obviously, in terms of deaths, we want to be able to identify the cause of deaths as well as comorbid conditions at time of death, because someone may die of a heart attack, but they are a cancer survivor or may be living with cancer. So we've heard recently in the last few talks about hepatitis B and hepatitis and HPV vaccines. So we really need vaccine registries so we can track who has been vaccinated and how we can improve access to vaccines as well as compliance with recommendations for vaccines. Similarly, we've heard a lot about cancer screening. We need cancer screening registries so we know who has been screened. We know what the follow-up is after an abnormal screening test. And we've heard this morning about what screening is feasible. Certainly cervical cancer is feasible. We've heard some discussions about breast cancer, colon cancer. In some countries, we've started screening for lung cancer in people with a heavy smoking history. We know that we can screen for skin cancer. In some countries which have high rates of oral cancer, they've begun to screen for oral cancer as well. As I said, we need to work to make sure we have systems in place so we can track individual patients through the health system, and that's where it's critical that we have a national identification number that is linked to the medical record so that we can do the follow-up. We can check to see if patients get the appropriate follow-up. We can link the data to a pathology report, to an imaging report, to the multidisciplinary tumor management recommendations, and then to follow, be able to track whether that patient received the right treatment at the right time, whether that's surgery, chemotherapy, or radiation therapy. And then to know the cancer status. Is the person alive without cancer recurrence? Are they alive living with cancer? Did they die because of the cancer, or did they die from something other than cancer? And then we can look to evaluate cancer quality and progress for cancer control, such as the number of the eligible patients vaccinated for hepatitis B and HPV, the percentage of patients screened for cancer, which we know is one of the WHO goals for cervical cancer, for example. The percentage of individuals with an abnormal screen who had the appropriate follow-up. That's often a missing data point. Countries or investigators will report the number of patients screened, but not what the follow-up has been. And obviously with our friends at IARC, we want to know the number of newly diagnosed cancers and the stage of diagnosis. In the United States, we're struggling to link our data so that we can track the completeness and the timeliness of the cancer care. As I said, the cancer status after treatment. Again, we really need to work as a community to make sure that we track and report on the like a 2-year and 5-year survival after treatment, and finally deaths due to cancer. So thank you very much, and I will, if anyone has questions, talk to me during lunch. And now our next talk is on supply chain management for cancer control.